The patient is a 77-year-old woman who presented to the office for a hospital follow-up from having a swollen tongue and difficulty breathing and swallowing. The patient stated she woke up at approximately 2:30 in the morning and immediately went to the emergency room due to a sore throat and swelling of her tongue. She stated she was having difficulty breathing due to an obstruction from the swelling of her tongue. Patient denied any previous history or similar experiences, and she denied any traveling outside of the country, exposure to unusual plants or animals, or other allergies. She has not started any new medications, used new lotions or perfumes, and has not eaten any unusual foods. In the emergency room, the patient was given or treated with Benadryl 25 milligrams IV, 125 milligrams of Solu-Medrol IV, and Pepcid 20 milligrams IV. For the review of systems, you have the constitutional, which she denies fever or chills, recurrent fatigue or malaise, headache, sweats, anorexia, fatigue, weakness, or weight loss. For ears, eyes, nose, and throat, she denies vision changes, light sensitivity, eye pain, irritation, double vision, vision loss, hearing changes, ringing in the ears, ear pain, nosebleed, nasal discharge, nasal congestion, non-healing sores, sore throat, difficulty swallowing, tooth pain, non-healing sores, or oral lesions. For cardiovascular, the patient denies chest pain or pressure, shortness of breath with normal activity, elevated blood pressure, difficulty breathing with lying flat, shortness of breath at night, shortness of breath that wakes you up from sleep, palpitations or sensations of heart beating in your chest, swelling in the ankles, lightheadedness, or weight gain. For respiratory, patient denies shortness of breath at rest or with exertion, cough, productive cough, difficulty breathing, wheezing, excessive snoring, shortness of breath, excessive sputum, chest discomfort, coughing up blood, sleep disturbances due to breathing. For gastrointestinal, patient denies heartburn or acid reflux, difficult or painful swallowing, nausea or vomiting, diarrhea, constipation, abdominal pain or cramping, bloody or black bowel movements, excessive appetite, loss of appetite, indigestion, nausea, gas, hemorrhoids, and change in bowel habits. For genitourinary, denies painful or difficulty urinating, blood in the urine, frequent urination, incontinence, urgency, incomplete emptying, and hesitancy with urination. For musculoskeletal, the patient denies joint pain, tenderness, or swelling, and denies changes in strengths. Neurological, patient denies frequent dizziness, fainting, weakness in arms or legs, numbness or tingling in arms or legs, headache that are not new or changing in frequency, difficulty with concentration, memory loss, sensation of room spinning, tremors, visual disturbances, weakness, inability to speak, and or seizures. For psychiatric, patient denies depression, hopelessness, anxiety, feeling stress, panic, obsessing, sensitive, suicidal thoughts, mental disturbances, hallucinations, financial hardship, not feeling safe at home, social problems that interfere with your mental or physical health. For the physical exam, for the general, patient is appropriately dressed, appearance is clean and kept, patient is a thin white female and does not appear to be in distress. Patient is alert and oriented ×3. For the ears, eyes, nose, and throat, there is no swelling of the tongue or throat. Mucous membranes are moist and pink. There is a normal pharynx without lesions or exudates. There is no deformity or lesion of the exterior ear. Canals and tympanic membranes appear normal bilaterally. Tympanic membrane intact and not inflamed with normal light reflex, and the patient is hard of hearing bilaterally. For the neck is supple, no masses or palpable cervical nodes. Trachea is in midline. Thyroid without nodule, masses, tenderness, or enlargement. The lungs are clear upon auscultation, and there is no extra sounds. The cardiovascular, there is a normal S1 and S2, no rubs, no gallops, no murmurs or carotid bruits. Musculoskeletal, no muscle pain or weakness. The skin is intact and is warm and dry, and there is no rashes observed or noted. Neurologically, the patient is grossly normal. Diagnostic studies or tests. Lab work that I reviewed from the hospital included the comprehensive metabolic panel, the PTT, and the complete blood count, all of which were within normal limits. The patient is feeling fine today within the office, so a follow-up lab work was not performed as there was no reason for the follow-up labs to be ordered. A C1 through C4 levels could be tested, and that if they were decreased, the patient had a C1 inhibitory complement deficiency. An EGD was done in the hospital to rule out if there was a foreign object blocking the patient's airway while she was in the hospital, and this was gone over with the patient during the appointment to rule out the possibility, and it was shown that there was nothing that was obstructing the patient's throat. Some of the differential diagnoses that I'm going to go over is like an allergic reaction, drug-induced allergic contact dermatitis, or C1 inhibitor deficiency that could have caused the patient's edema in her tongue and her throat. It is unlikely that it was caused by a mast cell-mediated etiology that increases vascular permeability through mast cell degranulation and release of inflammatory mediators, include allergic angioedema, autoimmune mast cell release, and direct mast cell release caused by medications such as opiates and radiocontrast media. It is not likely this type of reaction because these etiologies are associated with urticaria and pruritus, which the patient did not have. Also, the patient did not have an exposure to a new pet, food, lotion, or any other allergen or medication that could cause an allergic type reaction. The patient also does not have any history of autoimmune disease or any reaction similar to this in the past. For drug-induced, it is more likely that the etiology is kinin related, where angioedema results from generation of bradykinin and complement-derived mediators that increase vascular permeability. Since there is no urticaria or pruritus, the most likely cause is the altase or the ACE1 inhibitor that the patient has been taking caused an increase in bradykinin since it decreases angiotensin II, which degrades bradykinin. Bradykinin can then interact with vascular receptors, increasing vasodilation, vascular permeability, increased GMP, and release of nitric oxide. This reaction occurs in 0.1 to 7% of the patients treated with an ACE1 inhibitor, and it typically involves the mouth, lips, tongue, larynx, pharynx, and subglottic tissues. Half of these cases usually occur within a week of starting the ACE1 inhibitor, but can occur years later. This is a class-specific reaction, not a drug-specific, and ARBs can cause the same reaction even though those drugs can't affect the kinin metabolism. 50% of patients with angioedema due to ARB also have ACE1 inhibitors induced angioedema. Deficiency of C1 inhibitors can cause angioedema since levels of complement are reduced and cause increased bradykinin. This can be due to the lack of the C1 inhibitor or inadequate amounts of non-functional C1 inhibitor. Other causes of angioedema can also include aspirin, NSAIDs, since inhibition of COX enzyme pathway increases formation of the pro-inflammatory leukotrienes. Other possibilities in the differential of causes of swelling include cellulitis, autoimmune conditions including SLE, polymystosis, dermatomyositis, and Sjögren's syndrome. Hypothyroidism can cause puffiness of the face and the lips, and hyperthyroidism can cause an infiltrative dermopathy, and superior vena cava syndrome in tumors can cause venous engorgement and swelling. It is not likely one of these etiologies since the patient is not an ACE inhibitor and the swelling is restricted only to her tongue and throat, which is a typical of ACE1 inhibitor angioedema. For management for this patient, for medication, the patient was given a script of corticosteroid to decrease inflammation and protect against the relapse after initial improvement. 4 days of dexamethasone 20 milligrams PO was given to the patient to help decrease of inflammation, and after being discharged from the hospital, she has 1 day left of treatment. The patient was instructed to finish the treatment. The patient was also prescribed Benadryl for an antihistamine to block inflammation as well. She was given 4 days, 25 milligrams PO once a day. Once again, the patient has 1 day left and was instructed to finish the prescription. The patient was also instructed to discontinue her Altase or the ACE1 inhibitor that is likely causing her angioedema. Patient will be started on an alternative hypertension medication to replace the ACE inhibitor. It could not be hydroxyzine because the patient has a sulfa allergy, and also the patient has asthma and COPD, so beta blockers may not work well either. The hypertension medication chosen to start the patient on is a calcium channel blocker, which is diltiazem, 120 milligrams once a day. It is helping the patient's blood pressure as relevant of what the blood pressure was today at the office. The routine following up and ongoing care is having your follow-up appointments with your physician is important so the physician can monitor your systems and help monitor the patient's progress and blood pressure. For the prognosis of the patient, in this case with our patient, the patient does not appear to have significant swelling in her tongue or mouth today. The patient states she is doing well, and it was ruled out that the swelling was caused from her ACE inhibitor, in which she has now stopped, and was put on another medication, which is working out for her well. The patient agreed to follow up in 1 month to review her meds and agreed to contact the office if she was having side effects and if the swelling returned and she may need to go to the ER or the emergency room. The patient agreed.